To set a context, we know that healthcare is 18% of gross domestic product and going up 3 to 4% faster than gross domestic product, which tells us that by 20 years from now, it's going to be 36% of everything that is spent and consumed in the United States, an impossibility. We know in spite of spending 50% more than any other country in this world on healthcare, our quality is maybe average amongst the industrialized nations. And in 7 months, we have healthcare reform. 34 million more people being insured. And there's debate going on, obviously, in Washington, D.C., as the federal government grapples with the deficit and with changes in Medicare. Healthcare has to change very significantly in the next couple of years. The only question is how. How will it change? And that's what today's discussion is going to be about. On one hand, we're privileged to have Vinod Khosla, who is a graduate of the Stanford Graduate School of Business. He was the CEO of Sun Microsystems, and he's currently the founder and head of Khosla Ventures, which is an entrepreneurial company focused on clean technology and information technology, and very much a believer in entrepreneurship and the power of technology to change the world. We're also privileged today to have Abraham Verghese, who is a New York Times leading author, books Cutting for Stone, My Own Country. He's a professor at Stanford Medical School and an expert in infectious disease and a major believer in the power of the doctor-patient relationship and the importance of the human touch in helping to cure patients and advance medicine. So let me ask Vinod to begin by offering his thoughts on what needs to happen in healthcare going forward.
Thanks. I'm probably the least knowledgeable about healthcare in this room. I'm probably more naive than anybody else, and I actually think that's a good thing. Mostly because I believe change will not happen from within the system. In most major industries, it hasn't happened from within the system, so I think it's extremely unlikely. Cutting healthcare costs is the same as saying to every healthcare provider, your revenue should be half. That doesn't work. So let me start with sort of my naive point of view. The second thing I would say to you is I think of the US healthcare system as largely trivial compared to, in terms of the population it serves compared to the global population. It's less than 5% of the global population. So when we start gearing all our conversations around reimbursement codes and payment systems, that's not how the world works and most of the world works. It's some fraction of 5% of the people who behave that way. With that, let me start with what's wrong with the system. Fairly high percentage of misdiagnosed cases. And a version of this presentation is on our website, and the references are all in the notes, so you should be able to grab them. Misdiagnosis is as big a problem as breast cancer deaths or car accidents. That's what we are dealing with. More importantly, the information required to do the correct diagnosis is in many cases, if not most cases, in the patient record. When we talk about great caring doctors, it's great caring, somewhat error-prone doctors, maybe very error-prone doctors, cause more accidents than car accidents in this country. This is the other thing. I've had people argue with me on this, so not too many people at Stanford, but actually there's a US president who complained about the fact, lamented that 50% of Americans were below average. I won't go into that. But it's important to recognize that the concierge physician I have isn't the physician I'm talking about. If you go to rural India, they'll barely tell you what disease you have. They just tell you what to do if they bother to see you at all. So human doctors have plenty of cognitive limitations. If you want to understand them, read Dan Kahneman's book on thinking fast and slow. They have cognitive biases. I could spend an hour just on this slide, but in the interest of time, I won't. But let me give you an example. 100 cases of diagnostic errors involving internists. Cognitive factors, which is basically, when you say an experienced doctor, it is exactly the same as saying a biased doctor, a doctor with a set of biases. Because experience and bias are exactly the same thing. One of the big problems, premature closure. You walk in, see the doctor, in the first 15 seconds, he's decided. Major source of error, not asking the 3 extra questions because there's some rarer condition which could be very serious. I'll come back to this issue. Once you form a hypothesis, you only want data that confirms it, and the history of psychology is full of experiments to prove that all human beings do this. Human beings are relatively poor determinants of scientific facts. They love stories. One of my favorite stories is that the diagnosis of any disease, take a disease like ADHD, directly corresponds to the number of press references to that disease. If the press writes more frequently about ADHD, the number of diagnoses goes up because there's a recency bias. The physicians read about it. Somebody walks in, oh, you must have ADHD. Plenty of literature to support this. These are the great doctors we talk about. I'll come back to the problem. Now, Cleveland Clinic did a study of second opinions. In the majority of cases, a second opinion changed the treatment in some material way. Think about that. We love our doctors. We trust them. I trust my doctor. But in fact, if I got a second opinion on anything serious, likely the outcome would change. That's what this study said. One of my favorites, and everyone knows, is John Ioannidis, right here at the Stanford Medical School. He says, no matter which well-characterized medical study you take, it's more likely to be wrong than right. That's a direct quote from him. And I've been following him since when he was in Greece, because I've spent an incredible amount of time studying the question of what's called expert opinion. And there's plenty of literature. In fact, the most rigorous study on expert opinion was done by Professor Tetlock at UC Berkeley, who followed 250 experts across 28,000 individual forecasts for 20 years. And the average accuracy of experts was about the same as dart-throwing monkeys. If you want to read about it, a statistically rigorous treatment of expert opinion, read the book called Expert Political Judgment by Professor Tetlock. Here's another example. This is, I was asked to hide the procedure. 58 experts estimated of chances on the outcome of an important procedure that they were voting on to allow or disallow. These are all the probabilities they gave on the outcome. Now, if this isn't random, which of these doctors would you like? Depends on what outcome you like. Those were the actual estimates. Another one, 17 experts were asked to estimate the effect of screening on colon cancer deaths. What percentage of colon cancer deaths could be eliminated by colon cancer screening? This is random dart-throwing monkeys. Validates Professor Tetlock's hypotheses. Surgeons were given a detailed diagnostic and asked if patients should get surgery. This was in cardiovascular medicine. Half said yes, half said no. Now, which of these surgeons would you like? Let me tell you the worst fact. This wasn't bad. they asked the same surgeons the same day, gave them the same data 2 years later, and 40% of the surgeons changed their prescription. Now, who wants to have heart surgery? So my point is, what we get high confidence that we have good doctors, but low facts that we have good doctors in any given diagnosis. So that's without the bias of hospital profitability, physician income. There was a study I saw just recently this week that said emergency room patients who have insurance get more tests than patients who don't. That is the US healthcare system. So this is the study I was talking about, so I already covered it. So then the question becomes, how do you solve this problem? If that's the quality of care we're getting in the US, and if you can extend that to the quality of care you might get in a place like India, where the physician or the doctor-patient ratio is 10 times worse. I asked myself the question, how many more medical schools would you have to start? How long would it take to get 10x the number of doctors trained? Where would one get faculty to train, open up all these medical schools to have 10 times the capacity? The answer is, for most of the world, this is not a scalable solution. So then I started asking the naive questions and started speculating of what could happen. And I can tell you, whether you look at computing, pharmaceuticals, media, telecom, I can go on and on. In every significant case, and I've personally been involved through 30 years of being in technology entrepreneurship, change has been driven from outside the system, not from inside. So I'm now going to get into the domain of speculation, because there is no way for anybody, including myself, to predict what will happen. I'll come back to this issue. I personally believe the way change will happen is the patient becomes the CEO of his own health. He cares the most about his own health, he or she. And if we empower them, they will force doctors, hospitals, insurance companies to behave the way they should, because he cares about himself or she cares about herself. So my fundamental premise is the way change is likely to happen is the patient becomes the CEO of their health, not their doctor. A change in the balance of power. I would contend that 80% of what doctors do can in fact be replaced, not 100%. Let me tell you about a study a little company in Oregon called Lifecom did. Company was started by a surgeon whose wife visited the doctor multiple times. This is a medical professional, a surgeon, over the course of 3 years. And the doctors in this Oregon community sort of assumed away her disease, presumptive closure. Oh, you're having a numbness here, that's okay, it'll go away. Pretty common diagnosis. Take 2 aspirin. Turns out, 3 years later, she discovers she has Hodgkin's lymphoma. If you had put together all 6 visits longitudinally and looked at that as one record, there was no question she had something serious. But on any one visit, with her complaints, you couldn't say she had Hodgkin's lymphoma. It was discovered too late. He started this company to make sure. So what did this system developed in Oregon, which I would contend doesn't have the best technologists available? they did a study at an Oregon health clinic. Distributed care with medical assistance with only 1 year of medical training. Only requirement was at least a high school degree before you start your 1 year training. 91% accuracy. Then they looked at what they could safely triage in terms of incoming patients at an acute care clinic. 75%, and the bar was set pretty high to not miss a bad case. Similar data from other places. So I'm not going to go too much into the details, but the next question I have here is, doctors are much better at integrative care. I disagree. Across all symptoms, demeanor, patient history, we have a company that tracks your cell phone to see who you called, when you called, whether you change your pattern, or when you call your mom on Saturday mornings, or whether you even walk from your bedroom to your kitchen. This is a mental health application generally installed on patients' phones through their psychiatrists today. Knows much more about your history than you could describe a month later to your psychiatrist. That is integrative care. And looking back the last 5 years, automatically, every time you have a new blood test, that's integrative care. Knowing how your behavior changed. And the point is, machines won't be better at everything. But they will be better at more things than a human being, even the best ones, can possibly handle. The next question beyond integrative care comes up is this issue of the human element of care. I don't disagree we have the placebo effect. Somebody caring does change your outcome. I love Deepak Chopra. But if you want the human element of care, shouldn't you use the most humane humans? That may or may not be an MD, and you don't need an MD for that confidence-building activity. Confidence-building activity doesn't mean you can get away with bad diagnosis or incomplete diagnosis. Having both helps. I personally find the nurses are more humane than most doctors I run into, because the doctors, they're not bad people. They're just really busy. They're handling 3,000 patients, 15 visits a day. Boy, they're hurried. And in fact, enough studies say that when they walk in with a white coat of authority, patients are afraid to ask them questions that they feel are stupid. There's studies that indicate that patients are more comfortable getting directions from a computer because they can ask stupid questions, because they don't feel stupid. They don't feel like they're taking up somebody's time when they're rushed and busy. There's nothing wrong with doctors. That's not the point I'm making. What I'm saying is the circumstances are different. Now, as we transition to these kinds of technology-based systems, we'll see plenty of reports about stupid systems, oddities, but think of these as toddler MDs. If you imagine your kids learning how to walk and talk and be intelligent, they'll look more like the cell phone you had in the first version of the cellular phone. But that's not the phone we can live at. Today's systems, the next few years, will look like that. I call them Dr. Algorithm version 0. There will be point innovations. I don't have enough time, but to go into it. We can talk about each of these areas, but I see radical change happening specialty by specialty. These innocuous point innovations will become a wave and then a tsunami. And the nature of the healthcare system will change without us realizing it. I suspect nothing you learn in medical school today is going to be relevant, or very little of it is going to be relevant 15, 20 years from now. So if this is V0 of Dr. Algorithm, V6 in 2025 will look something like your iPhone. And if you think we're done with the iPhone, we are not. This is just the beginning of the next 10 years of V6, and by V16, we'll be in a different place. So think of these toddler systems as error-prone, and we should be used appropriately and not everywhere. But imagine 6 or 8 or 10 evolutions of this. I won't go into this. The best MDs will train these systems, not your below-average MDs. Initially, they will really just provide bionic assist in amplification of what doctors do. In fact, they'll be most helpful to the 50% below average physicians. So with Dr. House and no manners required, you'll move towards systems that are more patient, have more time. And these are computers. You can talk to your cell phone all day long. I won't go into data science as a contributor, but the early indications are it'll be stunning. And we will change what is the practice of medicine. We do what we did last year and 10 years ago and 20 years ago into truly the science of medicine. I think that's the big change coming, and half of medical practice that we practice today will be proven wrong. Don't have time, but I'll tell you, if your kid has high fever, it's probably a bad thing. In fact, the only study ever done says it's a bad thing to reduce that fever. But all your doctors will tell you to take some Tylenol and reduce that fever. Of course, I've talked about this. This has happened in lots of other areas, and let me finish with this. If you flew here, your plane wasn't driven by or flown by a pilot. Most likely, it was not a pilot. Only 10 years ago, 15 years ago, people said impossible to trust financial judgment, since this is the around investing, to computers. Today, there's not a place where computers don't do most of the hard lifting of investing. That was considered too judgment-oriented to allow humans, but the results come in pretty damn quick. Humans did relatively poorly compared to computers, and of course, self-driving cars. I'll be wrong in many, many ways, but I will be directionally right, so let me stop there. Thank you.
Abraham.
Pleasure to be on the same podium with Vinod and Robbie. Thank you for having me here. And as I listened to the talk, I was thinking what a tremendous time to be involved in healthcare, because I completely agree. The system is dysfunctional. It needs massive change. And what I'd like to suggest is it might be a tremendous opportunity for certain core values that I strongly believe in to make their way to the forefront, because they're cost-effective, they're timely, and because patients want them. And that's the case that I'm going to try to make for you. I should tell you that I'm a traditional sort of physician. I'm probably in that below 50% cognitively impaired, but very traditional, in the sense that when I see a patient, I listen to their story, because 80% of the time we know that you can make the diagnosis from what the patient's telling you if you listen carefully enough. And then I examine the patient. I like to think of the body as a text. It has a story to tell you, and if you learn to examine it well, which is what I spend my day training physicians to do, then you have additional information about what ails the patient. And typically, with those two pieces of information, you can then order tests judiciously so that you don't overexpose the patient to radiation. You don't send them on the kind of therapeutic misadventure that Vinod was referring to. That happens, by the way, all the time. That's the kind of physician I am. But I do want to say that I'm not a Luddite. I think this is important for me to state at the outset. We are not pitting technology versus anti-technology. Far from it. I practice in Stanford Hospital using the best of cutting-edge technology. I love it. I recently wrote this op-ed in the New York Times talking about how for years I used to carry a small doctor's bag with all my stuff in it. I loved the bag. It had just a lovely shape to it. I think I had a fetish about that bag. And then I stopped carrying it because most people were not carrying it. Even the neurologists who walked around with this all the time stopped carrying it. And so I resorted to stuffing things into my pockets. But of late, as I wrote in that op-ed piece, I've begun to carry a bag again because I'm carrying many things that give me much more accurate information. I carry a pocket ultrasound, a V-scan. I can get a good sense of cardiac contractility. I don't need to guess. I can see if there's fluid around the heart. I can look at the inferior vena cava during respiration and truly say this patient is dehydrated or is fluid overload, which is something we have a hard time doing just by examining the patient. I carry a panoptic ophthalmoscope. I can see beautiful pictures of the retinae, look at the vessels, and 80% of what I deal with at Stanford Hospital is vessel disease in some form, diabetes, hypertension, atherosclerosis. And to be able to see the substrate of what makes this patient tick is valuable. I carry an iPad to share with the patient their images. The images, the fantastic images we're generating all the time, really belong to the patient. And this allows me to complete the loop and bring the images back to the patient. And I spend my time trying to teach my medical students, my residents, that despite all the technology, we have an obligation to pick the low-hanging fruit. There's a lot of low-hanging fruit out there that you don't need expensive technology to make a diagnosis, and we should be really able to do that. We've just completed a study with John Ioannidis, actually, asking physicians to tell us about a kind of error that no one talks about. This is not the error of wrong site surgery or medication error. This is an error where one physician knows that another physician overlooked a key physical finding, which led to either a therapeutic or diagnostic misadventure. And that idea of low-hanging fruit that we're missing in the new healthcare system reform, I suspect that we'll be putting a lot more weight on making sure we don't miss the low-hanging fruit. I recently visited the design school with David Kelly and was so impressed with his working with prototypes and models, so I hung some low-hanging fruit under my desk. I don't know if you can see that. I have an apple under my desk, and on the shelf behind me I have some low-hanging fruit, but people walking to my office don't always seem to get the metaphor of low-hanging fruit. So I actually commissioned a cartoonist, John Branch, to do these two cartoons for me. This one says, as you can see, the guy has an ocean liner running through him, and he says, well, let's get a CAT scan and consult the gastroenterologist and figure out why you're having these pains. Another one says, let's get a CAT scan and consult the neurologist and figure out why you're having these headaches. We cannot afford to be missing the low-hanging fruit. It's a travesty on the most basic kind of training, whether it's for a physician or a physician assistant or a nurse, to miss things that are really out there for us to pick. But I would be remiss if I suggested that the entirety of the patient-physician relationship was about diagnosis. I hate to tell you this, but diagnosis, I wish more of the patients I saw, the issue was diagnosis. 75% of our healthcare costs in this country are spent on chronic illness. And the diagnosis is not an issue for the patient or for the physician. We spend so little of our time wrestling with diagnosis. I love it when a diagnostic dilemma comes in and we all put our heads together and try to solve it. I wish it were more common than it is, not for the patient's sake, but intellectually. Most of the time, the diagnosis is not the issue. It's caring for the patient in a manner that takes them through this suffering that really is the issue. And to that end, I want to share with you this very famous painting. It's the most famous, iconic painting in medicine. It's called, any guesses? The Doctor. It's called The Doctor by Luke Fields. He painted it about the late 1800s. It's the most famous, iconic painting in medicine for two reasons. One, it was wildly popular. It got onto postage stamps in many countries across the world. But two, because people have an emotional reaction to this painting, which is still kind of interesting to dissect. Just to give you the background, Luke Fields was commissioned by Tate of the Tate Gallery to capture a portrait of the doctor in our time. This is the late 1800s. And Fields chose to depict the scene of his son, Philip, dying on Christmas Eve at the age of 9, and the doctor who was in attendance. And he chose to portray the doctor in our time. That was his goal. And just to quickly take you through it, you see the child in the center, and something about the posture of the hand suggests how moribund and quite acutely ill this child is, sleeping on two dining room chairs that have been pulled together in what is otherwise a fisherman's shack. The child probably sleeps in the back of the shack at other times. You see the parents on the one side, and you see the doctor on the other side. And even though this is the era of the stethoscope, the reflex hammer, the blood pressure cuff, the ophthalmoscope, they have forgone all that in the picture and just focused on the doctor and the doctor's singular attentiveness. And there's been lots of papers written about what this painting means. And I must say, I disagree with most interpretations. I think this painting, despite the title, is not about the doctor. It's about you and me projecting ourselves into the role of the patient. And if we were the patient, this is the sort of attentiveness we want from a single individual, whether they be doing a strep screen on us or whether they be orchestrating a liver transplant and heading a large team. We nevertheless want some person to quarterback this and give us this kind of attentiveness. I think that's why this painting resonates. And I've often wondered, what if Luke Fields were alive today and was commissioned by, not Tate, but someone else to capture the doctor in our time? What would that look like? And my fear is that it would look like this. This is what the doctor in our time would look like. I have written about this. I've talked about how the patient in the bed has almost become an icon for the real patient who's in the computer, the virtual entity in the computer. And I've called that the eye patient. And ladies and gentlemen, the eye patient is getting wonderful care all across America. We couldn't be prouder. The real patient often wonders, where the hell is everyone? When are they going to come and tell me what's going on? Who's going to come and touch me where it hurts and actually evidence some interest in my complaints? We have a major disjunction between the technology that we have and patient satisfaction. I can't tell you how often I hear anecdotes of patients telling me they are missing something that we're not providing in the milieu of the greatest care that they could possibly be getting scientifically. This was one of my last slides that I just added today because it came to my attention. This 9-year-old girl depicted her visit to a doctor's office. And this is the painting she rendered. And when it came out, it caused great distress to the physician because he's portrayed as having his back to her while she sits on the examining table and her sister and mother sit in chairs. And this is one of our most talented physicians, served a year in the Navy on a battleship, has 3 children, chose to dedicate his life to pediatrics, believes in patient communication, believes in the sanctity of the patient-physician relationship, and felt that essentially the electronic medical record and the advent of that kind of technology, for all its great advantages, and I celebrate them, wound up spoiling and sort of changing something what he thinks is essential to the patient-physician relationship, and which I will argue I also think is essential, which is the ritual. In other words, there is a ritual to being in the presence of a healthcare provider, physician or not, that I think is important. I've learned from my colleagues in anthropology, Dr. Kerry Costanzo-Kapoor from anthropology, and I have written this paper on the bedside ritual. I've learned from my colleagues that rituals are about transformation. We engage in rituals to signal the crossing of some sort of threshold. Well, I would submit to you that the ritual of one individual coming to another and telling them things that they would not tell their rabbi or preacher or spouse, and that is the great, that's the great privilege I have of being a physician, that I get to hear things that people aren't ready to share with just anyone. And then incredibly, they disrobe and allow touch, which in any other context would be assault. I think that ritual is a terribly important one. I'm really struck, having moved to the Bay Area 6 years ago, at the variety of cultures here, Hmong and Tongans and people I haven't seen before. And they have all kinds of different views about healthcare. But they all believe in the sanctity of coming into a room, telling their story, being in this ritual. One person wears a white gown, the other person wears a paper gown, and hopefully being examined well, not just a cursory exam by an unskilled physician doing a poor job, but a skilled exam. Something important transpires. And I'd like to leave you with the sense that technology can disembody, but a skilled exam, and it doesn't have to be a physician, I completely agree, preserves the personality, the embodied identity of the patient, validates their complaint, and is a symbolic centering of the attention of the body. I want to close with this image to suggest to you that one of the most important qualities about the patient-physician interaction will continue to be the importance of touch and the human hand. Not in some hokey fashion, but only in this fashion of only the hand can touch where it hurts. Only the hand can bring some sense of reassurance and comfort. I'm astonished that we actually think that medicine is a science. You only have to round with me for 2 days in Sanford Hospital to recognize that there is so little science to much of what we do. It is about end-of-life care. It's about families in distress. It's about people suffering. I know Vinod has used the expression witchcraft to describe us in medicine. And I actually love that. Vinod, that's exactly what I do. I stand before you as the grand doyen of all the witches. And in the sense that so much of what we do isn't really about science. It's about human-to-human interactions. And I think in our hurry to jump on the bandwagon of advancing technology, and I'm all for that, we'll need to keep in mind that there are some very basic human desires on the parts of our patients that we can't alter. I'll close with this quote, which is from The Death of Ivan Ilyich by Tolstoy. A very powerful lawyer is suddenly sort of sick and turns out to be cancer, and the weeks and the months go by, and it's just getting worse and worse. And what he finds most hard is that no one seems to be able to give him what he needs, except this poor, uneducated peasant who works for him, who comes by and massages his legs and helps him to the bathroom. And this quote is interesting to me because it's so contemporary. It represents what I call the infantilization of disease, which renders people in need of another human being, often a physician, but not necessarily, to provide that touch. And this is what he says: what most tormented Ivan Ilyich was that no one pitied him as he wished to be pitied. At certain moments, after prolonged suffering, he wished most of all, though he would have been ashamed to confess this, for someone to care for him like a sick child, to be petted and comforted. He knew he was an important functionary, that he had a beard turning gray, and therefore what he longed for was impossible, but still he longed for it. Only in Gerasim's attitude towards him was there something akin to the caring he wished for. As Peabody said 100 years ago, the secret to the care of the patient is in caring for the patient. Thank you very much.
So there should be a URL flashing on the screen soon to send your questions to, and some of the students, you will have the chance to sort them out. And I get a chance to start with a couple of questions to my guest panelists. Let me start, Vinod, with you. Stanford's probably the most entrepreneurial business school in the nation. You presented an image of where we need to go 10 or 15 years from now. What advice do you have to the people in the room about what they should be doing next year and the year after to help get us there? And what Khosla Ventures will invest in?
So just a couple of comments first on what Abraham said. I'm completely a believer that human emotions are a big part of being a human being. And I just gave a talk. I gave a talk about 2 hours ago in San Francisco on mobile trends in mobile industry. And I said, I'm shocked that there aren't more applications that appeal to the human emotion, that emotion should be a different category of investing. Now, if some of you use Pinterest, to me, that's an emotional app. If you use food spotting, that's an emotional app. If you use Wattpad, which very few of you do, but it's sort of to the emotion of creative writing and creative reading. I'm not minimizing the effect that emotions play in human beings. What I am saying, in providing that, let's not delude itself that the person who can deliver that emotional comfort can also deliver the right diagnosis. So I sort of clearly want to separate the two. Creating the perception of caring or real caring. And I can tell you, if my kids have a diagnosis of X or Y, they'd much rather trust me than their doctor. And will sort of say, what do you think? And they know I'll go back and do lots of research, and I'll spend hours if they're sick, and then come back to that. because there's this relationship of trust, and we know trust in caring amplifies the placebo effect. So I'm all for that. If we can amplify healing through those things, absolutely. But that doesn't mean we should fool ourselves into thinking that human beings are good at actually figuring out the root cause that needs to then be addressed. Abraham gave the example of I can look into somebody's retina and look at the individual veins with great precision. That's great. But if you had a computer do that, it would also see what the retina looked like 3 years ago, and for him, probably 10,000 patients ago. That he can't instantly on the spot say, here's the change, which is really the diagnostic fact that matters in that case. And then say, hey, of the 9 million people Kaiser Permanente has served for the last 20 years, there were 722 cases of this kind of change, and depending upon one of 3 directions taken, this was the outcome of those 720 patients. That's the science of medicine. That doesn't mean that emotion and caring isn't a tool of medicine. I view it as a tool that should be addressed. So I just want to address that. Let me address the second thing, which gets to your question. Technology doesn't have to be expensive. I'll pull out my favorite new toy. This is an FDA-approved EKG machine. Costs about $15 to produce. And now, if I just fire up my app and put my fingers on it, my EKG shows up. Now, that's sort of cool. But if I'm a cardiac patient, do I want 2 EKGs a year that I get that cost me $2,000? Or do I want 5 EKGs a day, 1,500 EKGs for the year? Every time I'm feeling well, every time I exercise, every time I eat or go to sleep or wake up, just like a diabetic does on their blood sugar, with much less hassle and a lot more data. So I can find those anomalies that might show up in my heart patterns. And if I sent my doctor 1,500 EKGs, I don't know what he'd do with them. Only machines can handle real data. That's not to say after I know my diagnosis, know what I need, and I get the half of the surgeons who voted for surgery, what I should do about it. I want data science to tell me what happened for the 9 million patients at Kaiser over the last 20 years. That's what I'm talking about. If you're practicing medicine today, learn about. So here's a statement I've often made. In the next 15 years, data science will have more to do with improving medicine and medical care. I'm not even talking about reducing costs. I'm talking about improving medical care than anything taught in medical school. Anything being researched in any pharma company, any research operation, data science will cause more improvement in healthcare than any of those other things that have to do with biology. So if you're a student, you should think about that. If you're an entrepreneur, you should think about how you bring those tools, those first toddler systems to care. I'll give you a stunning example from Kaiser Permanente that George Halverson loves to talk about. A data scientist went through all the data at Kaiser's incoming stroke victims. Just stroke, incoming, outgoing. People either leave alive or dead. There's only 2 ways you leave the hospital, right? According to George, looking at a data analysis of incoming stroke victims, by changing the protocol, no new drugs, just it was how you administer statins and when, and you might know more about this, the death rate was reduced by 40%. Now, if your death rate goes down by 40% for incoming stroke victims, George would say there's not a single drug that has had that kind of an impact. And frankly, I'd rather be walking out alive than dead if I went in with a stroke. that's what I mean by, and so the entrepreneurs should be addressing that. That doesn't mean ignoring the human side of care. I just want to emphasize that, but you can create that perception. I'd rather have George Lucas taking care of me from the caring side than my physician. He's much better at emotion. Let me stop there.
So Abraham, well, first for the audience, I really recommend you buy Abraham's books. They're some of the best written books, Cutting for Stone and My Own Country. And My Own Country, he'll make comment on it, is a story about his experience early in his career as an infectious disease physician taking care of patients with AIDS before there was any treatment. And so the question I have for you is end-of-life care. People talk about it a lot. No one quite knows what to do about it. What are your thoughts?
Well, I think it's the number one issue for our house staff in terms of things that frustrate them, because we are very often in situations where we are giving futile care that's very, very expensive, mostly because people haven't come to terms with end of life in terms of families having talked about it, dealt with it. And in America, I always feel that death seems to be something of a surprise, as though we don't really know that life is a terminal condition and this is going to... I hope you all know that, right? You're all aware of that. Life is a terminal disease, and when it arrives, it seems to me that we're not ready as a society. We don't have a way of discussing it, talking about it, and so we engage in a lot of futile and expensive, health care, whether it be dialysis or maintaining life until everyone can agree that it's time to stop. So I think it's a major source of frustration. One thing that's been very gratifying for me to see in my time in academia is the emergence of the palliative care model and the recognition that we have to do and can do a much better job of end of life than the old model, which was, well, we've done all we can do medically, sorry, whereas for palliative care, that is the beginning of the story, and it tends to be a very rewarding specialty. As you know, some of the best people I know have gravitated to that, and they make a huge difference.
So let me go back to Vinod. There are 11 hospitals in New York City, and they're ranked in terms of outcome. And a former president of the United States, people may have different views about him as a president, but he had to have heart surgery, and he chose the 11th ranked one, the lowest one. How do we deal with human behavior in the context of medical knowledge?
Well, in the end, us as human beings, we have to make choices. I suspect he was a politician, made the political choice. I don't know. I'm much more interested in a different question, which is, well, how do we make the bottom 5 as good as the top 5? And I think that we can do. Today, the standard deviation around care is so large, just in the US, just in New York City, to your example. Imagine what it's like between the best New York City hospital or rural Indonesia. That distribution of the quality of care can be severely narrowed and improved. And done that by reducing the cost of care. I actually suspect as you reduce the cost of care for a variety of reasons, probably too complex to go into this short discussion, as you reduce the cost of care, the quality of care will go up. As you reduce the cost of computing, the quality of computing has gone up. In most areas where you get on a technology cost curve, you get both together, while the presumption normally is when you reduce cost, you reduce quality. I actually don't believe that. You force yourself into tools that are multiplicative. I call that bionic assist for physicians. But there's no reason, despite the AMA, that you can't provide bionic assist for nurse practitioners and then nurses and then medical technicians and down the line. That amplification of human capability and complementing them. And frankly, human beings love stories and they're irrational. And we all have our own biases. That's why you get 50% of the surgeons saying surgery and the other half saying not. We can eliminate that variability based on real data from 20 years of practice. So I think this is about narrowing the standard deviation of care first and making sure that we reduce costs, we improve quality. And again, I want to emphasize, I don't think this will happen from within the system. It'll come from empowering the patient through today's mobile and newer technologies.
You're in the system. What do you think, Abraham?
I want to also emphasize that so much of the perversion that we see in healthcare is driven by reimbursement. I mean, the peculiarities of reimbursement, where you're paid to do things to someone as opposed to for someone, which is why a great percentage of our Stanford Medical School graduates, at least in years past, not so much anymore, I'm pleased to say, are going to dermatology. They talk about the road to success amongst the medical students, and the road being radiology, orthopedics, anesthesia, dermatology. That has so much to do with income. It doesn't have to do with their passion and their particular interest. And the skin is interesting, but it's not that damn interesting. We have 10 times the rate of bypass surgery that you see in Canada without results that are much different in terms of overall mortality. Clearly, when you pay for something to be done, it gets done to excess. And I think we have a very expensive model. I want to sort of, just make sure that I'm clear with Vinod that I'm all for data. I mean, evidence-based medicine has been one of the most wonderful revolutions in medicine. We're not sitting there at Stanford Hospital, sort of taking guesses on what to do. We use data as much as we can, but we always come to a point where there isn't data. And we need to sort of generate more data, or there's a subjectivity that we can't quite erase in the present time, but 10 years from now we might have more data points. For example, I mean, I suspect that the operation the surgeons were asked about was gallbladder surgery. And, I've heard surgeons, not here, elsewhere, tell me the indication for gallbladder surgery is a walking, breathing patient. That's the only indication. They can ascribe any symptom to that. And that has to do with reimbursement. So I don't think we can meaningfully talk about best practices till we also implode the system, bring about change in healthcare financing.
Do you see, when you talk about the road, which is the 4 specialties that pay well and actually don't have a lot of nights and weekends, do you see a generational issue happening in the future of healthcare?
Well, I think we're already seeing, to my great satisfaction, we're seeing many more people going into family medicine and internal medicine, primary care specialties, at a time when they're not necessarily reimbursing more. I think it has to do with the fact that we have just recruited a wonderful generation of medical students. They're in it for the right reasons. They see that the future will require many more primary care specialists, and they are sort of answering the call, I suspect.
So let me ask you, I got some questions from the audience. Is there a role for technology to augment the doctor-patient relationship?
Absolutely. Next 10 years, that's what you'll see. That's what I call bionic assist, or amplification of the best surgeons. And it'll be most useful to the bottom half of the doctor population. They will need the most help, and they will get the most help. And they'll get better. And we'll still have 50% of doctors below average, but the average will be much higher because of that bionic assist. I do believe that.
So I'm going to ask a question to Abraham that was written to you, Vinod, but I would like to hear Abraham's thoughts on it first, and then have a chance to comment. Most patients are accustomed to taking a passive role in their care. Studies have shown many patients prefer it that way. What will catalyze patients to take a more active role?
Again, I think it depends on what patient you're talking about. I've spent the greater part of my career in county hospitals where patients were very disenfranchised. They didn't have this notion of being able to control their health care. They didn't have access to the web. So if you were to ask me about that patient population, I would say that a paternalistic sort of relationship continues to exist in that patient population. Here at Stanford is very different. I think my patients are very well informed. They come to you asking tough questions. They've done the web search. They're ready to contest anything you say, which I think is healthy and good for the system. I don't see patients here as being disenfranchised or disempowered. I think that they are, for the most part, very well aware of choices and the errors that can be made in medicine, and they come to us with that sense.
They exercise, eat well, manage their weight, manage their blood
Well,
pressure.
I think, my advice to those of you who are seeking to do something exciting in entrepreneurship, just look around and see how much of disease has to do with personal choice. And if you can make an impact on the number of people who are, drinking to excess or smoking or living sedentary lifestyles or not acting on their family risk factors, That, I think, will make a huge impact on medicine.
Your thoughts, Vinod?
So I agree. I personally believe that from very many different directions we'll get data we can act on. I'll give you a simple emotional example. I wear my jawbone band. About 3 weeks ago, it sent me a little message saying, congratulations, you're among the top 30% of jawbone users in the number of steps you take per day. Now I hate missing my exercise because I might fall back out of that 30. So suddenly it's motivated me to, one, leave this on, and two, make sure I go from top 30 to top 20%. And that's motivation. It's, you could say rationally I could do this without the band and know how much exercise, but we are human beings and we respond to stimuli. I'm not sure I answered your question. Maybe you want to repeat it?
Well, more, again, from a technological standpoint, what can we do to help Americans get healthier? We know chronic disease is the #1 cause. Abraham talked about 75%, and much of that is lifestyle driven.
Yeah. So, you know, today, today, the analogy I would use is if you put a frog in a pot of water and heat it very, very slowly, it'll never jump out. You put a frog into a boiling pot of water, it jumps right out. Vice President Al Gore used this analogy when he talked about climate change. Because change is so invisible to us, that extra dessert we eat doesn't show up, that exercise half hour you miss doesn't show up in some visible feedback to us. We tend to follow immediate desires, that desire to just be a little lazy and sleep in instead of exercise this morning, which I did, or have that dessert because there's no consequences. If we start getting feedback, humans respond to gamification. Let me give you an example in another area. Most people never pay attention to their utility bill. How much do you spend on electricity? Utilities have figured out if they include one little graph, here's how much electricity you used and here's how much your neighbors used, suddenly everybody's electricity use starts coming down. It's a little bit of gamification. It's very much like this band saying to me on my iPhone, hey, you're in the top 30% of step takers. Now I'm motivated. So I think technology can definitely feed that motivation. It can give you other feedback. If I'm sort of getting high blood pressure and I'm measuring it continuously, it can tell me what's happening. If I get feedback, I can do something about it. Now, I suspect a third of the people will never do anything about it. A third will always do something, and then there's those in the middle who react somewhat, but not completely. So, human beings are not all alike, but I do think technology can play a big role in feedback, and then if you use human psychology to amplify that, which is what all the game companies do. That's how they addict you to words with friends. It's an addiction, or that's why BlackBerry was called Crackberry. Creating the right positive addictions, I think technology can do.
So let me give you the last word, Abraham. Are you optimistic or pessimistic about the future of American medicine?
Well, I'm an eternal optimist, so I'm actually very optimistic in the sense that I think that it's so dysfunctional that anything has to be better. But I also think, as I said at the outset, I think in a funny way, I've toiled in the fields preaching the value of certain basic good qualities that I think a physician should have. And I think in a cost-effective world, those qualities will be, valued and amplified, and we will train a cadre of nurse assistants and physician extenders to also have those values. So I'm actually really excited.
So let me just close with the perspective that, at least from my viewpoint, that we have to be high-tech and high-touch, and that one or the other won't work. We could be great high tech, but without the high touch, people just simply won't follow the information that they have, whether they're doctors or nurses or patients. And if we're only high touch, then we won't have the information that we need to figure out where to go. And like probably both of you, I'm very optimistic that we'll succeed, and it'll be the people in the audience who will help us to lead the way. So thank you very much.